Welcome to AETCM, the Emergency Medicine Channel. Today we are going to discuss the most prevalent monsoon and post-monsoon fever, that is dengue fever. As per the Indian Society of Critical Care Medicine guidelines, which were released on recent 10th August, we are going to discuss about a case. A 40-year-old male presented to ER. Initial primary survey, airway was patent, breathing respiratory rate was 20 per minute with saturation of 96% on room air, and BP was 90 by 60 mmHg with a pulse rate of 122 per minute, sir. Coming to disability, GCS was E4, V5, M6 and pupil bilateral equal and reactive. Patient was conscious oriented. Next, coming to environment, the temperature was 101 degree Fahrenheit with GRBS of 125 mg per DL. Right now, the patient was having a fever with tachycardia and hypotension. So, initial management of first fluid bolus of 10 to 20 ml per kg per hour was started, sir. Apart from that, 1 gram PCM was also given to the patient. And coming to the adjuncts of the primary survey, VBG was showing no acid-base disorder, and CBC CRP, which was drawn for the point of care, it was showing thrombocytopenia of 50,000 platelets, sir. Apart from that, neutrophils are on the lower side, 3,500 were the leukocyte counts, sir. And there is an outside documented report showing that he was having dengue NS1 positive, sir. So regarding the further management which we need to be taking care, first thing we need to be taking care of the triaging. Regarding the present guidelines, the triaging would be as our triage has normal yellow and red, green, yellow and red. The patients which are having dengue fever with no warning symptoms. So defining initially what are the warning symptoms. Warning symptoms are those which the patients, when they are having recurrent vomiting or because of they are unable to take any food intake, and next, if they're having continuous abdominal pain or tenderness, or the patient is having generalized weakness, letharginess, or if there is any documented evidence of third space volumes, that is mild pleural effusion, ascites or pericardial effusion, or if the patient is having an hepatosplenomegaly, or if he's documented that hematocrit is greater than 20% of the baseline. These all are considered as the warning symptoms. In our case, the patient was having recurrent vomiting and patients having generalized weakness for last 2 days. So we are considering the patient to be in warning signs. So if a patient comes without such warning symptoms or without bleeding, that we can consider to be a green area and we can treat as a OPD basis. Patients having either these warning symptoms or a comorbid condition, previously comorbid conditions, are high risk patients. The list of high risk and comorbid conditions are defined as if the patient is an infant, old age, or having a comorbidities like diabetes, pregnancy, CAD, or even hemoglobinopathies, or if a patient is on steroids or immunocompromised or even on anticoagulants. These are all considered as the high risk conditions. So dengue with warning symptoms or high risk comorbid conditions are considered under the yellow triage and have to be observed before discharging the patient. Next, coming the severe dengue. In this classification, we need to involve the patients who had come with significant hemorrhage, that is bleeding, or patient with shock. And previously, dengue was classified as dengue hemorrhagic fever with class 1, 2, 3, 4. 4 being the dengue hemorrhagic fever with shock. That comes under severe dengue. Or if there are multi-organ involvement, more than one organ involvement, or if there is a severe metabolic disorders, these all are considered under severe dengue and they're placed under red triage area and they're admitted. This is the triaging system as proposed recently, sir.
Most of the patients, what we see, will have some
warning
hypertension.
Symptoms and hypotension.
Most of them will have hypotension.
Yes. On arrival, usually the patients can have the warning symptoms or multi-organ involvement and or we can say like bleeding, acute bleeding. That is the major presentations to ED in India. Next, regarding the diagnosis of dengue, the laboratory investigations which we use at present availability is dengue NS1 antigen, either ELISA based or the commercial rapid kits are present. Next is the dengue IgM.
ELISA is not for antigen, ELISA is for antibody.
Yeah, yes.
Dengue IgM.
ELISA based is dengue IgM and IgG. Okay. Rapid antigen detection kits is for dengue NS1. Okay. Basically, dengue NS1 has a higher specificity and sensitivity, whereas IgM and IgG are having high specificity and lower sensitivity. Regarding the NS1...
That can be asked only after the fifth day or sixth day of fever.
Dengue NS1 is right now used for 1 to 5 days of fever. In the duration, dengue NS1 will be used. Above 7 days, dengue IgM can be used, and dengue IgG is used to see if there is a secondary dengue infection. So that can be used from the first day itself.
Okay.
And dengue IgM has.
But in an endemic area, most of the patients will have IgG positive. IgM positivity comes after 5 to 7 days. NS1 will be the most useful test in acute dengue.
Setting. Dengue IgM or IgG can have some false positive reaction because of cross reactivity other falciviridae like Japanese encephalitis virus or West Nile virus. But in our setting, there can be cross reactivity even with malaria, scrub typhus. So we need to consider the possibilities of cross infections. Regarding how do we consider whether the patient is requiring an ICU management or just an observation? For that, patient if with already diagnosed dengue or not diagnosed probable dengue fever is having fever for more than 5 days of illness with a systemic dysfunction or shock or the dengue NS1 antigen or IgG antibody tested positive proving that it is a dengue with previously explained severe signs of dengue. For them we require to be put in the ICU admissions. Next, regarding the clinical and laboratory parameters which should be monitored in a severe dengue patient which was admitted to ICU. Regarding the monitoring, we have to monitor the general condition, appetite, vomiting and even mucosal bleeding, which is a trivial amount of bleeding which can happen in mucosa like gum bleed, skin or the oral cavity. Skin such as petechiae, rashes, these all should be monitored every 6 to 8 hourly in an ICU setting. Or the peripheral perfusion, which is done by the pulse rate, blood pressure, capillary refill time and urine output. These are the indicators of shock. With every 2 to 4 hours they should be monitored. And rest coming to our vital signs such as temperature, BP, respirate should be monitored 4 to 6 hours. In a normal dengue patient which is admitted in ICU, otherwise in shock, more frequent monitoring is required. Regarding the laboratory tests which are more useful in monitoring in an ICU patient, two very important are the reduced peripheral perfusion, capillary refill time and serum lactates are the markers for our perfusion, organ perfusion. And patients with shock who are already in shock, regarding the monitoring, we need to do a serial hematocrit every 6 to 8 hours. We should be noted that hematocrit, when we take the blood sample for hematocrit, it should be done either before resuscitation with the fluid boluses or post resuscitation. But during the boluses of the fluid, at that time, hematocrit should not, the lab should not be withdrawn, blood should not be withdrawn.
What will happen?
It will be diluted because we are giving the fluids, we cannot appropriately diagnose.
So what happens in hematocrit in acute dengue?
In acute dengue, because of the basic pathophysiology of dengue comes with the capillary leak mechanism, because of which there will be third spaces fluid loss and intravascular blood, the volume of the blood will be reduced. So the concentration of the blood cells, that is the hematocrit, increases. Okay. So we are expecting greater than 20% hematocrit than the baseline value for...
Hematocrit is a very useful investigation in acute dengue. Or even in trauma or any other fever, if it is elevated, that means a large volume is lost to third space.
So the hematocrit, depending on the hematocrit also, a lot of the guidelines are based on the hematocrit, sir. Next, other important parameter in ICU setting is the urine output. Every 6 to 8 hours, if it's non-invasive, like it's not catheterized, every 6 to 8 hours we can check the urine output. In normal patients, estimated urine output should be around 0.5 ml per kg per hour. If that is not attaining, then we need to consider that the patient is in shock.
Not in shock, it is hyperperfusion of the tissues. Cannot tell it is shock. Yes. Shock is defined as persistent hypotension in spite of starting all 3 lines of treatment, including fluid,
ionodrops, vasopressor.
When patient requires ionodrops. So that then only shock definition will come, not 3 lines of treatment. After fluid, if you are forced to start ionodrops, then it is defined as shock clinically. Yes. But otherwise, there are a lot of other definitions.
So urine output tells us the hypoperfusion of the tissues. We need to monitor. Next, regarding the biochemical parameters which need to be monitored, recommended baseline investigations for any dengue fever is the CBC, blood glucose, all the electrolytes and the liver function test, renal function test, even a chest X-ray, and even if the patient is complaining of persistent abdominal pain,
Chest
even
X-ray is for what?
chest X-ray is for the baseline X-ray. If there is an organ involvement like ARDS setup, then
This is not very common in dengue. What is common in dengue? What X-ray findings are common in dengue?
pericardial, like pleural effusion is the most common.
Is the most common finding. Rarely you can get ARDS can occur in any disease, but not very common in dengue.
For the pleural effusion, we can use. And also cardiac enzymes if you are suspecting myocarditis, and even serum amylase, lipase value if there is a persistent abdominal pain on presentation. Even baseline USG is recommended to check for if there is any free fluid in the abdomen like the ascites, or if there is any pleural effusion, pericardial effusion. And the expert group which provided these guidelines are against the frequent repeating platelet counts, like not more than twice in a day, to check if the platelet is dropping trend or not. And also if the patient is overtly bleeding or platelet count less than 10,000, avoid repeating the CBCs. And if the expert group also recommends evaluation for secondary HLH in diagnosed dengue patients if there is a persistent fever or recurrence of fever beyond 7 days, and also if there is any new onset organ dysfunction beyond 7 days. In the workup of the secondary HLH, we need to send CBC, serum ferritin greater than 3000 is a significant value, serum LDH, serum triglycerides, and bone marrow examination if required. Depending on that, we calculate H score. H score greater than 169 indicates a high prevalence of HLH in the patients.
Okay. So ferritin is one investigation which can easily tell patient is developing some sort of macrophage activation.
As it's an acute phase reactant, it is the first.
Very high levels of ferritin may indirectly indicate.
Yes. Next, regarding the treatment priorities in a severe dengue virus infection, the first and the foremost important priority is the fluid supplementation. As the culprit is the capillary or third space fluid loss, we need to correct the intravascular volume using the crystalloids as the major supplementing fluid. Next, regarding the fluid supplementation, which has to be preferred, crystalloids or the colloids for that. The expert group recommended that albumin infusion can be used, but judiciously only we use when there is a large number of crystalloids are required and there is a huge quantity of third fluid volume. Judiciously, we can use albumin as the correction, but mostly crystalloids are the only line of action. Colloids are not the preferred choice unless if there is a blood pressure which has to be restored urgently. And if the pulse pressure,
colloid you are talking about?
Albumin is the colloid. Dextran and the other colloids are having far more risk factors rather than the benefit factors, so they are avoided.
What is the risk?
They'll cause acute fluid overload and heart.
What is the risk of
anaphylaxis?
What is the risk of colloids in any patient? That's why nowadays we don't use it. What is the problem of colloids? Other than albumin. Albumin is safe. What is the problem? If it goes out from the blood vessel, it cannot be absorbed back like albumin. So if it goes to the lungs, then patient definitely develop ARDS. Okay, ARDS-like features. That's why nowadays we don't use colloids at all. If the vasculature is good, it will maintain. Suppose there is a vascular leak, should avoid all these things. Anyway, we are not using, and it is completely removed from the clinical practice. But sometimes it can be very dangerous when we are using colloids, especially dextran and artificial colloids.
So only the indication for colloid is that to albumin is if there is any pulse pressure less than 10 mmHg and blood pressure has to restore urgently, and already lots of crystalloid fluid has been given to the patient.
Albumin should be given only after crystalloids.
The most common and the first priority is to use isotonic solutions such as 0.9% saline and ringer lactate. Rest recently, like right now, we have balanced fluids which are available, can be used as an advantage if we have to reverse the metabolic acidosis effectively, but they are expensive, so we'll restore. Next, now dividing the patients, we have like the dengue fever with warning signs, without shock. In such a patient with warning signs but without shock, initially we have to start with 5 to 7 ml per kg per hour of fluid for just 1 to 2 hours, then reduce it to 3 to 5 ml, then reduce it to 2 to 4 ml, as per the clinical response, and we can reduce or we can ask for the oral feeds. So during this point of giving the fluids, we will monitor using the HCT, that is a hematocrit, every 2 to 4 hours. If hematocrit remains same or it is rising, then we need to increase the fluid by 2 to 3 ml per kg per hour for another 2 to 4 hours. If there is any worsening signs or if there is any bleeding or if the hematocrit rapidly falls, then we need to consider there is a chance of bleeding and we need to consider the alternate therapies other than the crystalloids. And also the group advises to use clinical status, that is the capillary refill time and POCUS in cases of elderly males, or if there is any heart failure, liver failure, lung failure patients, to judiciously use the amount of fluids which have to be given to the patient. And the other parameters by which we can know whether the amount of fluid is adequate or not is to see adequate urine output and if the HCT is decreasing below the baseline value of the patient. Once the HCT comes back to the normal or goes below, then our fluid resuscitations can be withheld or stopped for that time. Next category, and apart from the fluids which we are additionally giving, we need to remember that there is a maintenance fluid which should be given for 24 hours. For the calculation of the maintenance fluid, we need to use by holiday and cigar formula. Just like for the first 10 kg it is 100 ml per kg, for next 10 to 20 kg it is additional 50 ml per kg, greater than 20 kg we need to add 20 ml per kg. Apart from this holiday cigar formula, we need to consider 5% losses in ICU setup. So this will be the maintenance fluid. Above this, these are the
5%.
Sir,
What is that 5%?
that is by the evaporation, respiratory losses,
Insensible
and
loss.
sensible.
What is insensible loss? Sweating is not insensible. It is sensible loss. We can sense it. Insensible loss is what? What is that insensible?
Insensible loss is the patient during the breathing
From the lungs.
humidification loses the.
So that is insensible. We cannot assess how much is lost. Around 500 ml in ICU can be lost like that.
And also regarding the fluid strategy, they are recommending conservative fluid strategy as compared to liberal fluid strategy. Like a balanced approach of 10 ml per kg to maximum 20 ml per kg fluid can be only be given rather than overtly.
What is this conservative and liberal strategy of fluid resuscitation?
Normally sepsis we will use 20 ml per kg, or fluid resuscitation we will use 10 ml per kg.
Like furtherly, if even the BP is not, the blood pressure is not rising, we should not be going on giving fluid bolus or increasing the fluid volume.
So there is no point in giving large volume of fluid in especially this type of condition. If BP is maintained around 100 and 100 by 80, we should be satisfied. We should not give more fluid. That may push the patient towards ARDS or fluid leakage and overload condition. So we should
further complications can be there. Now we are talking about the patients in severe dengue with warning signs and compensated shock. Earlier it was 5 to 7 ml per kg is the initial treatment. Right now we start with 5 to 10 ml per kg per 1 hour. Then again we see the responsiveness. Gradually we reduce to 5 to 7, then 3 to 5 and 2 to 3. A serial decrease will be there as per the timeline. Again here also we use hematocrit as the factor, check whether it's responsive or not. So if hematocrit increases or it's still high, greater than 50% even after the first bolus of fluid, we can repeat a second bolus of crystalloid solution at 10 to 20 ml per kg for 1 more hour. But if there is no improvement even after the second bolus, then we need to reduce the rate to 7 to 10 ml per kg and continue the same fluid, and we need to consider the second line of management, that is the inotropes in such conditions.
Okay.
The inotropes of choice as per the recommendation is norepinephrine in these cases.
Okay.
Next patient is severe dengue with shock.
Which condition you use dopamine as first line drug?
Other patients,
Any patient who is having hypertension not responding to
hypertension with bradycardia, drug which is
Radical.
Otherwise, norepinephrine will be a better choice than anything else.
Next group of people who are having severe dengue with shock. In these patients, as we deal with the sepsis 10 to 20 ml, here also we can initially start 10 to 20 ml per kg as a bolus for 15 minutes, rapid bolus. After that, we again give another bolus 10 ml per kg per hour for 1 hour. After these 2 pints of boluses, then we again say the HCT, hematocrit. If hematocrit is below 50%, then as previously we go 10 to 20 ml for 1 hour, then 7 to 10, then 5 to 7, slowly progress. But even after this, if the patient is not responding, then again we go back to inotropes. Next, coming about the transfusions, when should we transfuse to the patient? The expert committee has strongly recommended against transfusion of the fresh blood if the patient is having trivial bleeds like a mucosal bleed, a skin bleed, and hemoglobin is greater than 8, then they are not proposing for the PRBC transfusion. And in cases when it's hemoglobin less than 8 and if there is an active bleeding, fresh bleeding happen, then only we need to transfuse the blood. We need to use hemoglobin as the marker rather than the skin, like not just for any trivial bleeds not to transfuse. If hemoglobin is less than 8, then only to transfuse. And second, if concomitant comorbid conditions like heart is involved, then 10 is the value to be decided. Next, regarding the role of steroids in severe dengue fever, there is a strong recommendation against the use of steroids in dengue fever as of now. But if the institutional policy or research ethical committee is there, then they can use it. Next, regarding about the FFP transfusion or the platelet transfusion, there's against the transfusing of blood in severe dengue patient with absence of active bleeding, and prophylactical transfusion of platelets also should not be done, and transfusion of platelets should be done only if it is below 50,000 and if there is any surgical or minimal invasive procedures are planned, then only we need to transfuse. Okay. And next, various guidelines have advised that if the count is less than 10,000, then judiciously, clinically, you can allow for prophylactic transfusion, because below 10,000, even the cerebral capillaries are also prone for bleeding.
So the other conditions you get low platelets other than dengue and ITP?
Sir, various viral fevers, like so usually viral fevers.
Most of the viral fevers you can have little thrombocytopenia. HIV is one condition you can get significant thrombocytopenia. Then CLT. These are the 3 important conditions you get thrombocytopenia in clinical practice. And ITP is anyway you can get ITP, immunological
disorder. Anemia sometimes
also. But that will not be it cannot be very severe. But HIV can be sometimes severe. CLD can be severe. Dengue can be severe. Malaria can be severe. Leptospira can be severe. These are the common conditions we come across.
Next, regarding the complementary alternative therapies, as of now, the guidelines have not, studies have not proven the usefulness of papaya leaf extract, such kind of things, so they have advised not to use them. And regarding using of anti-D immunoglobulins, rompiplastin or L-Trombopac in severe dengue with thrombocytopenia, there are no studies showing that they're having useful roles, so they're advised not to use them. But because the reason is that there are far more complications using them, like fluid overload or trolley can be seen in such conditions. Next, regarding the extracorporeal therapies for cytokine removal or plasmapheresis in severe dengue, this also is recommended against that, because there are no such studies proving that they have a better approach in the outcome of the patient. Next, regarding the criteria when we can shift the patient from ICU to ward, the criteria is the shock should be resolved for more than 24 hours and there is no overt bleeding for more than 24 hours and there is no fever observed for more than 24 hours and there is improvement in the organ dysfunction or improvement in the platelet count, then we can shift the patient from ICU to ward. Okay. Regarding the guidelines for discharging the patient from the ward, clinically there should be no fever for more than 48 hours after stopping the antipyretics and improving in the clinical well-being, appetite, hemodynamic status. Laboratory wise, there is a stable hematocrit for the last 24 hours and there is an increasing trend of the platelets, then we can discharge the patient. Regarding the special population such as the elderly and pregnancy, in the first trimester of the pregnancy, usually there is a wide pulse pressure, but clinically if there is a narrow pulse pressure and in the first trimester there will be increased chance of pre-eclampsia and eclampsia, so we need to admit the patient under the ICU. Okay. And regarding the second trimester, there is the risk of more complications as compared to other trimester in such patients. Regarding the third trimester, there is no much increased risk as compared to mother or the fetus, but fever during the third trimester can cause preterm labor. So we need to have a better antipyretics control. Regarding the postpartum patients, postpartum pregnant females, there is be no any difference in the dengue patients, but there can be this thrombocytopenia can increase the risk of postpartum bleeding. So we need to take care of that. Regarding the elderly patients, most commonly elderly will have the comorbid conditions of heart failure, liver failure, or lung failure. So judicious use of fluid should be used, not overtly correcting the fluid balances. So these are the specific guidelines which are published for now.
There is no new things, but they have put it in a
Systematic algorithmic manner.
Only important thing is they are like repeatedly telling hematocrit values.
We have to use the hematocrit as the major factor, like for whether is our treatment working or not. Apart from that, regarding the definitions which they had given right now, dengue is any acute short febrile illness of having 2 to 7 days, with most common symptoms being myalgia, arthralgia, retroorbital pain, and there can be rash or cutaneous bleeding.
Okay.
And severe dengue is defined as a dengue fever with the capillary leak, signs of capillary leak, bleeding or shock or organ dysfunction. And as I previously discussed, the warning symptoms, any one of the above would consider the patient being dengue fever with warning symptom.
Okay.
And dengue hemorrhagic fever, they had given the guideline that patient having a criteria for the dengue fever plus any evidence of hemorrhagic tendencies proven by positive tourniquet test or petechiae ecchymosis, or there is bleeding from the mucosa, GI tract or injection site, plus thrombocytopenia less than 1 lakh, and there is an evidence of plasma leakage by the clinical finding of increased hematocrit or more than 20% drop of the hemoglobin, or there is signs of plasma leakage because by seeing pleural effusion, ascites or hypoproteinemia. This is the definition.
Want to add something? I think.